I'm Dr. Shweta Santhalia from AIM MRCOG, and today we are here to discuss the most recent TOG of Peripartum Cardiomyopathy from 2021 TOG. This is the fourth volume. This Peripartum Cardiomyopathy is always an important topic, and I'm very happy that it has come in the recent TOG, so we don't have to search the different sources for the material. It's always important for a TOG, which is always asked in the exam. If we get a proper source, proper information in the TOG, then that topic becomes easier for us all. So let us discuss about peripartum cardiomyopathy. So why it is important? First of all, we have to understand that why peripartum cardiomyopathy is important. So if you see in recent memories, they have written that out of cardiac causes, cardiomyopathy is the most common cause. If you see, it is 27%. They have written in the talk that nearly 1/3 of the women are dying because of cardiomyopathy. That's why the cardiomyopathy, we should know about it. We should be able to answer the question about it. That's why this talk become important. Cardiomyopathy could be idiopathic cardiomyopathy, or it could be peripartum cardiomyopathy. If you see, most of the time, this peripartum cardiomyopathy will be presented towards the end of pregnancy or up to 6 months following delivery. What does it mean? Usually, whenever a cardiac problem present in pregnancy, usually it will present at the end of the second trimester, because there will be 50% rise in the volume, 50% rise in the cardiac function, cardiac output. Most of the cardiac problems will be presenting at the end of second trimester. Peripartum cardiomyopathy will be presenting towards the end of the pregnancy. So they say in the last month, like after 36 weeks, or up to 6 months following delivery. This is a very important point for your differential diagnosis. How they formulate the question is they ask you about what is your diagnosis. So for your diagnosis, whenever they give you after 36 weeks or up to 6 months following delivery, and usually later we will see that it is most commonly presenting up to 4 months. Definitely they will give you that duration. If they want you to diagnose peripartum cardiomyopathy, they will give you the patient either after 36 weeks, or they will give you patient in the first 4 months or 6 months after delivery. So if you see that duration, it should click in your mind that they are going to talk about peripartum cardiomyopathy. This is how, according to duration, you can get a hint that what diagnosis you have to choose. Other important aspect of peripartum cardiomyopathy is it is a diagnosis of exclusion. Diagnosis of exclusion means you shouldn't find any other cause for her cardiac symptom, then you will label it as peripartum cardiomyopathy. This is very important. When they say in the talk that you don't have to only exclude the thing, but you have to try to diagnose the thing. So if you don't find anything, then you will label it as peripartum cardiomyopathy. What will be the characteristic of it? Yes, it is a diagnosis of exclusion, but then how you will diagnose? That is also important. There should be some feature that you will tell that it is a peripartum cardiomyopathy. First of all, I told you about the duration, at what time it will present. And the other important aspect will be in the echocardiography. Echocardiography is the most valuable diagnosis for peripartum cardiomyopathy. What you will see in echo, you can see that the heart is dilated. You can see it may be dilated, it may not be dilated. So heart could be dilated, the left ventricle could be dilated, and the ejection fraction will always be below 45%. This is important. This is a characteristic. The ejection fraction has to be low, and it should be at least below 45%. Then only you will diagnose peripartum cardiomyopathy. This is the diagnostic feature of peripartum cardiomyopathy. If you see the etiology, they say earlier they used to say that it could be because of genetic predisposition, and they said that because of the cardiovascular changes in pregnancy. But as I told you, if it is because of cardiovascular changes, should have presented at the end of second trimester. So now they have come up with that it is multifactorial. So what does this multifactorial mean is they are genetically predisposed for the cardiac problem, one thing. And the second thing is because of the vascular hormonal insult, then they are developing the PPCM. So this is what they want to tell about multifactorial origin. They are not sure about it completely. So they have labeled it as multifactorial. Am I clear about this slide? Okay. Okay, good. Now, if you see the etiopathogenesis, you will see that they have mentioned two-hit hypothesis. What is this two-hit hypothesis is, as I told you, genetic predisposition with vascular hormonal insult. What happened as the pregnancy advanced, the prolactin level increased. And once the prolactin level increased, there will be this, because of the oxidative stress, atepsin D is going to break the prolactin to 16 kilodalton A prolactin fragment. And this is the one which is going to cause the endothelial damage. The same way, in the later half of pregnancy, there will be increased soluble FMS-like tyrosine kinase receptor 1. And this will increase and this will affect the vascular endothelial growth factor. That's why, again, there will be endothelial dysfunction. So if they ask you what is the etiology, there is increased 16 kDa prolactin and increased serum soluble FMS-like tyrosine kinase receptor 1. These two things will be increased, leading to endothelial dysfunction. And that's why she is developing the cardiomyopathy. Now, the risk factors are very important because the risk factor will always be there in the question. If they want to choose, if they want you to choose peripartum cardiomyopathy, you should look for the risk factor. Good thing about the questions are they will always mention some of the other risk factors, so that and the duration, that these two will be the catchy point for you to diagnose it. So usually it will be seen in the women of Afro-Caribbean lineage. Here they say that Afro-Caribbean lineage women are more at risk, 1 in 300 like that. Usually the risk is 1 in 4,000, and in Afro-Caribbean women like Nigeria and Haiti, there the risk is 1 in 300 to 1 in 100. So definitely this nationality become important. So sometimes in question they will give you the nationality, so you get a idea that they are talking about PPCM. And they will give you multi-para women. They will give you multi-para. Sometimes they will give you multiple pregnancy. Sometimes they will give you obese women. Sometimes they will give you advanced maternal age. Older than 30 is a risk factor for PPCM. So age is important. Then the personal history, multi-para, multiple pregnancy, obesity is important. And then if she's a known chronic hypertension or if she developed preeclampsia, these are also the factor which will contribute to the peripartum cardiomyopathy. So definitely these risk factors are very, very important, and some or the other risk factor will always be there in the question if they want you to choose the peripartum cardiomyopathy. The diagnosis is the most important. Differential diagnosis is the most important. Sometimes they will make an EMQ for the differential diagnosis of cardiac problems. So you should know when to diagnose peripartum cardiomyopathy. Now, if you see the clinical presentation, most of the time, it will present as systolic heart failure. If cardiomyopathy means the heart muscles are not working well, so what will happen? Heart will fail. So there will be systolic heart failure in its clinical presentation. How it will present clinically? It could be mild or it could be suddenly progressing to the severe end-stage heart failure and ultimately death. It will be a variable pattern, ranging from mild to severe. If you see, as I told you, 78% of the women will present in the first 4 months after childbirth. So usually they will give you that duration if they are talking about PPCM. If you see what symptoms she will develop, so all the symptoms of heart failure we know, like dyspnea, difficulty in breathing, orthopnea, paroxysmal nocturnal dyspnea, pedal edema because of the heart failure, unexplained cough, which will be more on the lying down, frothy pink sputum. This is characteristic of the heart failure. So frothy pink sputum is very important finding. Dizziness, palpitation, fatigue, chest pain, and abdominal discomfort because of the hepatic congestion. So if you see, some symptoms are non-specific. Some symptoms are like usually we see also dyspnea, we see in normal pregnancy, dizziness, palpitation, fatigue. These all we see in normal pregnancy also. So pedal edema also we see in normal pregnancy. So what will be the characteristic will be paroxysmal nocturnal dyspnea, unexplained cough, chest pain, and discomfort. So this is very important for us to see what is important in the symptoms, which gives us an idea about heart failure, so that we get an idea that they are talking about heart failure. Now, what will be the examination finding? In examination, you will see there is signs of heart failure. What will be the signs of heart failure? Again, there will be sinus tachycardia. There will be raised venous pressure because of the heart failure and lung crepitations because of the pulmonary congestion. These are the findings you will get in the examination. So these are all related to the heart failure sign and symptoms. So how you will diagnose? We have already seen that it is a diagnosis of exclusion. So diagnosis of exclusion means any patient come with a cardiac problem. Definitely you are going to take a history. You are going to do the examination. We have already seen what we are going to look for. And then you will do an ECG. Any cardiac problem if you suspect, you have to do ECG. You will be definitely doing some blood tests to rule out infection, to rule out troponin T, means myocardial infarction, all that thing you will be doing. And then you have to do the echo. This echo, as I already told, is crucial in diagnosing PPCM. So in ECG, there will be no specific pattern because but ECG is very important investigation to rule out other things. But if you do ECG, you will get to know if she has any MI pattern, if there is any ischemia pattern. So definitely ECG is important. ECG is always the first investigation. You will do it definitely. But as it is diagnosis of exclusion, in ECG, you will not find anything. There will be no specific pattern in PPCM. It could be ischemic pattern, it could be non-specific ST rise, it could be anything. So blood test, if you do, you will rule out other things. That's why you are doing. So hemoglobin, C reactive protein, WBC, and troponin T, all this will rule out infection for you. But the most important thing in blood test is natriuretic peptides. This is the marker of heart failure. So this is important in blood test to diagnose PPCM. And then in echo, definitely we see the ejection fraction. If it is less than 45%, it is diagnostic of PPCM. And as I told you, ventricle may or may not be dilated. Other investigation could be chest X-ray, MRI, and rarely biopsy. These all will be if needed. So you are not going to do it always. If clinically you think that there could be any infection like pneumonia, there could be pulmonary embolism, there could be other things, then you have to do this other investigation. But ECG and echo and blood test, these three are the mandatory investigation. So what is the benefit of echo? As I told you, this is the most useful one for diagnosis as well as the prognosis. So how it helps in prognosis? It helps in prognosis. If you see the left ventricular size is more than 6 centimeter, means dilated ventricle, and if the ejection fraction is less than 30%, then the prognosis is poor. Poor prognosis means it will not recover spontaneously, and most of the time it will need mechanical support. It will need heart transplant, or sometimes it can lead to death also. So these are the poor prognostic factors for PPCM in echo. Am I clear about this diagnosis part? Okay, good. Now, if you see ejection fraction correlation, it is very important. Sometimes I can ask you, what does it mean? So if ejection fraction, left ventricular ejection fraction is less than 45%, it diagnoses the PPCM. If it is less than 35%, then you need anticoagulation for the patient because there will be risk of stasis, there will be risk of arrhythmia and thrombosis. Arrhythmia and thrombosis are the two most common complications of PPCM. So anticoagulation will be required if the ejection fraction is less than 35%. If it is less than 30%, it is poor prognosis, we have already seen, and they need mechanical support and transplant. They will not recover spontaneously if the ejection fraction is less than 30%. If it is less than 25%, then pregnancy is contraindicated. This is very important point, that in less than 25% ejection fraction, you will tell her to use effective contraception and avoid pregnancy, because pregnancy is contraindicated. Even if she becomes pregnant, if pregnancy is contraindication, you have to offer her termination. Better for her that she avoid pregnancy altogether by using an effective method of contraception. This is the importance of ejection fraction in the PPCM. Now, as I told you, heart failure sign you will discuss, you will diagnose by natriuretic peptide, right? So if you see, if the raised natriuretic peptide, if BNP is more than 100 or NT-proBNP is more than 300 and ejection fraction is less than equal to 45%, these all are very characteristic of heart failure and diagnosis of PPCM. So you will consider PPCM in that case, and you will involve cardiology. So brain natriuretic peptide and N-terminal pro-hormone brain natriuretic peptide is a must investigation in cases of PPCM. As I told you, echo. So these two things are must, and this will give you a clue about it is PPCM. But if it is normal, if it is less than 100, less than 300, and ejection fraction is good, then PPCM is unlikely. So you have to think about non-cardiovascular causes. Okay, now if you see the differential diagnosis, as I told you, most of the time they want you to diagnose a cardiac condition properly. They're not expecting you to know everything about the cardiac problem, but at least you should be able to diagnose and do the differential diagnosis. So what is the differential diagnosis and how you will differentiate it? So it's clear, if you see benign dyspnea of pregnancy, it will be gradual onset and there will be no associated cough. Cough will never be there in normal pregnancy. So cough is the catchy point, that there will be no cough, there will be no raised venous pressure, there will be normal heart rate and saturation of oxygen. So that's how you are the physiological condition you can easily rule out. Then comes the arrhythmia. If there is arrhythmia, definitely she will present as palpitation followed by heart failure. So history of palpitation is very important in arrhythmia. If they want to give you embolism, amniotic fluid embolism or pulmonary embolism, in both the cases, it will be sudden. Sudden onset is very important in these cases. So sudden onset is important. And in amniotic fluid embolism, we know the triad of cardiac problem, the triad of respiratory problem and DIC. So respiratory, cardiac and DIC, this is the triad of amniotic fluid embolism and it will be sudden. In the diagnosis, you will find raised D dimer. So this is how you will diagnose amniotic fluid embolism. In pulmonary embolism, definitely there will be some history of high risk of pulmonary embolism. So history will be important. Again, it will be sudden onset and you will do the usual workup. If there is asthma, definitely there will be history of asthma. So they will give you, she's a known patient of asthma. If there is pre-existing idiopathic dilated cardiomyopathy, this is the important thing, that idiopathic dilated cardiomyopathy and pre-existing valvular heart disease, which is unmasked by pregnancy, like rheumatic valve disease, mitral stenosis and all that, you will be finding it at the end of the second trimester. So if they want you to diagnose these two conditions, they will always give you presentation at the end of the second trimester. They will not give you in the last month and 6 month postpartum. So this is the important catchy point to differentiate from the idiopathic dilated cardiomyopathy and rheumatic heart valve diseases. As well as in idiopathic dilated cardiomyopathy, there will be larger cardiac dimension compared to PPCM. So this is how you will differentiate these two conditions. If there is hypertension, there will be pre-existing previous hypertension. If there is HIV, they will give you history of HIV. All this you can, if you know that something you have to look for in the history and something you have to look for in the presentation. If they give you sudden onset, automatically it clicks to you, either it is embolism or sometimes chest pain, and sudden onset it will be ischemia. So like that you will be able to differentiate. If they give you history of valvular heart disease earlier, idiopathic dilated cardiomyopathy earlier, asthma earlier, hypertension earlier, so they are talking about that. This is how you will make your differential diagnosis. And definitely any heart patient, you will do the ECG. In ECG, you will see the MI pattern. In ECG, you will be able to see some ischemia, which will help you in diagnosis of MI. If we do echo, we will get to know about the dilated cardiomyopathy and PPCM. If the brain natriuretic peptide is raised, it is suggestive of heart failure and it is characteristic for PPCM also. If they give you raised D dimer, they are talking about amniotic fluid embolism. So definitely they give you some clue in the question. If you know the point, definitely you can catch that from the question and make your differential diagnosis. So as you see in asthma, HIV, all this, you will see the history. There will be sudden presentation in embolus. There will be history of chest pain in ischemia, and there will be history of palpitation in arrhythmia. So this is all about differential diagnosis of PPCM. Okay. Now, if you see the management, definitely whenever a patient comes with any problem, first you have to confirm the diagnosis. So you will do ECG, blood test, chest X-ray, and echo. After that, you will look for it if the baby need antenatal corticosteroid. So you will give from 23 plus 6 days and up to 35 plus 6 days, you have to give the corticosteroid in cases of PPCM and cardiac problem. So this is what the antenatal corticosteroid role. Then it will be in the multidisciplinary team care. You will look for heart failure severity. Severity is always important because if it is severe, then you have to think about terminating a pregnancy if she is not improving. So you have to look for all the signs like tachycardia more than 130 or brady less than 45, respiratory rate more than 25, saturation less than 90, lactate more than 2, oxygen saturation less than 60%, altered mental state, cold skin, oliguria. These are signs of shock. What you will do, severe failure and cardiogenic shock. So definitely, first of all, you have to maintain her preload. How you will maintain the preload? By giving the volume. But because there is heart failure, the heart is not able to handle it, you want to give diuretic. So you have to keep a balance. How much volume to give and when to give the diuretic. You have to give vasodilator to increase the preload. So this is all important for you to understand that patient might need all this treatment. The main goal of yours will be to optimize her oxygenation. You want to keep her saturation 95%. You will give her vasopressor because heart is dilated, heart is not working properly, ejection fraction is less. But in this condition, you will not give her catecholamines or dopamine. No adrenaline, no noradrenaline, no dopamine. So what you will give will be levosimendan. Levosimendan is the vasopressor you are going to use in cases of PPCM, which will be 0.1 microgram per kg per minute. You will plan urgent delivery because she is in heart failure, she is in shock. So you will plan urgent delivery, but vaginal route will be preferred always until unless there is reason for cesarean section. You will consider bromocriptine because we have seen the prolactin is high in cases of PPCM and that is the etiology. So you will give her bromocriptine, which is antiprolactin. Now, bromocriptine, you will be giving 2.5 milligram daily for 1 week. That is the usual dose. But if the ejection fraction is very less, like less than 25%, in that cases, you may have to give a longer course, like 8 weeks therapy. So you will give for first 2 weeks, you will give BD, 2.5 milligram BD. And the next 6 weeks, you will be giving 2.5 milligram OD. So there is a role of bromocriptine in cases of PPCM. This is a new thing they have mentioned. And levosimendan to be used as a vasopressor is a new thing. These two words, these two drugs, you have to remember well. Then still, if she is not improving, you can consider mechanical circulatory support. If she recover, well and good. If she doesn't recover, then you may have to consider the transplant, heart transplant. So this is important aspect. Now, if there is severe heart failure and shock, it depends on antepartum and postpartum in PPCM. So if she is antepartum, then we have to look for the baby also. So you cannot give her any drug which is harmful for the baby. So definitely you will not give her ACE inhibitors. You will not give her mineralocorticoid receptor antagonist. ACE inhibitor is receptor blocker. You cannot give. So what you have to depend on is hydralazine and nitrate for heart failure therapy. Beta blocker is safe in both the situation, and diuretic you can consider in antenatal period because the diuretic can affect the uteroplacental flow. So you have to use it cautiously in antenatal, but in postnatal you can easily use the diuretic. So beta blocker is always safe even in antenatal and postnatal. Diuretic you can consider in antenatal period, but you can easily use in postnatal. ACE inhibitors and all angiotensin receptor blocker and mineralocorticoid receptor antagonist only for postnatal, and hydralazine and nitrate for antenatal. So this is how you are going to treat her for heart failure. Am I clear about this treatment model? Okay, great. Now, if you see the checklist for the management of acute heart failure, what all you have to look for if there is acute heart failure, it will be multidisciplinary approach, definitely the cardiologist, intensivist, and obstetrician, everybody, neonatologist, all will be involved in the women care. So you will avoid the drugs with teratogenic risk. I already discussed with you ACE inhibitors, and these all things you cannot give. You will consider bromocriptine, we have discussed already. Anticoagulation, we have discussed that we have to give if the ejection fraction is less than equal to 35%. And in this women where you are treating with bromocriptine, because the bromocriptine leads to increased risk of thrombosis. That's why whenever you are treating with bromocriptine, you have to give her anticoagulation with low molecular weight heparin. So it's important. In cases of shock, definitely you want to give her vasopressor, so you will give levosimendan. It is very important. You will transfer to specialist care. So this is very important how you will manage a heart failure patient. These are the drugs you have to look for: anticoagulation and levosimendan, and consider bromocriptine. Now, if you see the safety profile, I told you beta blocker safe in both the situation in pregnancy and lactation, and diuretics you have to use carefully in pregnancy. You will discontinue as soon as possible diuretic. You will not give it for a longer time. The same way the vasodilator, you will discontinue when they become asymptomatic. So this is an important point. For vasodilator, you are giving nitrites and hydralazine. Now, what about these drugs? How long you will give this? So this you will, they say that there is no consensus that how long you have to give. It will depend upon till her ejection fraction improve. But complete recovery you will be wait for, but at least you will be needing for 1 year. So please remember it that at least you will be needing for 1 year, and you have to avoid these in the antenatal period. So these are the safety profile of drug. Drugs are always SOG favorite. So they always ask you which drug you can use, which will be safer, which will be unsafe. So you have to keep that in mind. Now, what are the pregnancy specific consideration? If you see, as we saw already, the most cases will present, 78% will present postnatally. So it is important. Then if she present antenatally, you have to do consideration of the baby. So what are the effect of medication on the fetus? What are the effect on the growth? So fetal growth monitoring is important. Choosing the drug, which drug safe, which is not, is important. The biggest consideration will be timing of delivery. You have to keep a balance. You don't want to deliver a premature baby, as well as you don't want to compromise mother health because of the condition. So mother is always more important. So you have to keep a balance and consider when to deliver. Your goal will be, if she's stable, you want to take her at least till 37 weeks. But if it is not possible for the women, for the safety of the women, then you will deliver her early. And as I told you, the route will be vaginal always, and cesarean will be reserved for the indication, ops indication, where there is contraindication for vaginal delivery, or if the mother has severe maternal compromise. Corticosteroids we have already discussed. Intrapartum monitoring, which is very important because this any cardiac patient, if you monitor her in the labor, it is very important that you do the hourly monitoring of fluid balance. Senior person will be seeing them 4 hourly. Then you will give them 30-degree left tilt to increase the circulation and avoid the aortocaval compression. Then you will always check, you will keep her under continuous ECG, you will do pulse oximetry, you will assess the cardiac output by non-invasive techniques. So these are the crucial aspects if you are managing any cardiac patient in labor. Then you will always try to give them regional analgesia because pain will further increase the cardiac output and it will affect your condition. So low dose regional analgesia is what you have to give to her to make her comfortable and avoid the pain. Again, you want to cut short the second stage by instrumental delivery because that will put pressure on the heart. The pushing is going to put pressure. So you have to give her instrumental delivery, which will help in cutting short the second stage. Then for third stage, you have to give a slow infusion of oxytocin as the first line. You cannot give her long-acting oxytocin. You cannot give her ergometry. So you have to give her low dose oxytocin. That will be the first line. And the second line will be misoprostol and carboprost. So this is very important that what you will give her in the third stage. You will never give her carbetocin. You will never give her argometrine. You will always give her low dose oxytocin, which is important. And if that is not controlling, the second line will be carboprost or misoprostol. So this is about intrapartum management, how you will manage the second and third stage, and how you will monitor her continuously, give her left lateral tilt. Breastfeeding, they say that there is no consensus that you cannot the women cannot feed the baby. She can feed the baby if she's stable. So definitely if ejection fraction is less than 45% and she's unstable, she will not be able to feed. Otherwise, she will be able to feed. And also you have to consider the drug. So the drug which are safe in breastfeeding, you have to use that drug for the breastfeeding women. So these are all about the pregnancy specific consideration. If you see the prognosis is good. 50 to 80% will recover. That is a good news. That means the ejection fraction will improve to more than 50%. While if you see 10%, there will be mortality. Earlier, they used to say the mortality was 30 to 50%. But now, because of all the advances, thanks to the science that we have improved so much, that the mortality has decreased to 10%. So sometime even in SBA, they can ask you how many percentage will recover or how many percentage will be mortality. So this is very important. The prognosis you have to remember. Then the prognosis depend upon the Afro-Caribbean lineage. We have already talked that the PPCM is more common in Afro-Caribbean women. And the prognosis also is poor in them. So you have to remember that. And then in cases of the contrast thing is, in cases of hypertension with PPCM, the prognosis is good. So you have to remember that how the prognosis is affected by the different factors. Now, subsequent pregnancy, this is very, very important because they will ask you that previously she had a PPCM. Now, in this pregnancy, what all things you have to consider? Means what are her chances of getting worsening? What are her chances of dying? What are her chances of improving? So all these things you have to remember. The recurrence is always very important. So if you see, if she has persistent left ventricular dysfunction, means her left ventricular has not improved completely, the ejection fraction has not become more than equal to 50%. In that case, she has some residual thing. In that case, there will be 50% chance of further deterioration. It's important. 50% chance of further deterioration, and there will be increased morbidity and mortality. Mortality may be as high as 20%. So mortality is doubling. In places of 10%, now mortality is 20%. So this is important. 50% chance of deterioration. So this is important to remember these figures. If there is complete recovery, means the left ventricular ejection fraction has improved to more than equal to 50%, complete recovery is there, then definitely the prognosis will be better. But still, there is chance of relapse, which will be 20% in places of 50%. So it has decreased, but still there is chance of relapse. So both these percentage you have to remember. If there is complete recovery, 20% relapse, and in cases of persistent residual effect, 50% deterioration. Important, and 20% mortality. Now, what are the contraindication to pregnancy? Very important because they make a scenario. They will give you a scenario that women ejection fraction is less than 25% at initial diagnosis, and it has not normalized over course of time following medical care. So definitely, if her ejection fraction is less than 25%, you will tell her not to become pregnant. And if she become pregnant, you will offer termination. If they give you in question her ejection fraction is less than 25% and she's 7 weeks pregnant, what you will offer her? So you have to offer her termination because pregnancy is a contraindication for her health. This is important. This slide is really, really important. You have to remember everything out of it. Now, how you will manage in subsequent pregnancy, this is also important. If she has the history of postpartum cardiomyopathy, peripartum cardiomyopathy, in that case, you have to give her the care with MDT. So preconceptional counseling with MDT is important. Any medical condition, you have to do the preconceptional counseling. It will be done with the multidisciplinary team. A review of medication will be done and the medication which are harmful for the baby will be stopped. And then You will do early booking for them. It will be consultant-led care for them. There will be frequent antenatal visits. As I told you, there could be growth retardation. With beta blocker, there is chances of IGR. So you have to monitor the baby. You will continue treatment with beta blocker because as we saw, it is safe in antenatal as well as postnatal period. You will follow them closely with echocardiography and brain natriuretic peptide because we have already seen that this is the one which indicate that there is heart failure. Level of BNP more than 100 and the pro BNP more than 300 is what we are looking for. So it's very important that you monitor her with echo and BNP levels. What will be your echo timing? If you see the echo timing, first you will do in the preconception period, then you will do at the end of first trimester, at the end of second trimester, and then the most crucial period, which is 1 month before delivery, after delivery, and 1 month after delivery. This is very important. This can always come in question that when all situation you will do echo for her. So these are the fixed timing. And if there is any clinical sign and symptom of worsening, at that time you have to do echo. As we all know that in echo, if the ejection fraction is less than 45%, it indicates PPCM. So echo timing is very important and definitely it can be asked in SBA. Am I clear about this? Excellent. Okay, good. How you'll manage in subsequent pregnancy, we have already seen. We will consider all that factor, monitor her more, echo, BNP, everything will do. Then anticoagulation with low molecular weight heparin might be required if our ejection fraction is less than 35%. We will do serial scan to monitor the fetal growth from 24 weeks. Sometimes they make an SBA saying that this is her condition. She has a previous history of PPCM. Now, what all things you will give her? What is recommended and what is not recommended? Like that, they will make an SBA. So anticoagulation will be required, fetal growth monitoring will be required. These all things you have to, echo and BNP monitoring will be required. These all you have to keep in mind. Timing of delivery, again, as we discussed earlier, it will be according to OPS indication or if her condition is becoming severe. Your goal is to reach at least 37 weeks, but if her condition is deteriorating, definitely you will deliver her early. You will deliver by vaginal birth. That is always the preferred mode. You will give her anticoagulation at least for 6 weeks. Postpartum, at least for 6 weeks is required. Earlier, if she has PPCM in that pregnancy, you might need to give her even for 6 to 8 months, according to her situation. But in subsequent pregnancy, it is required only for as a high risk, as any high risk factor we give for 6 weeks postpartum, we will give her 6 postpartum. Contraception counseling is very important because some condition we have already seen. If ejection fraction less than 25%, we don't want her to become pregnant. So contraception is very important and you can give her all the LARC. All the LARC means IUCD you can give her, which is non-hormonal, and all the progesterone containing hormones you can give her for the contraception. You don't want to give her estrogen because there is chances of arrhythmia, there is chances of thrombosis. So you don't want to give her estrogen containing pills. So the only option left with you is either progesterone or non-hormonal containing. That's why copper IUCD or implant or injectable DMPA or Mirena. So this is what your option will be. If you want to put copper IUCD or Mirena, you have to do it in hospital setting. This is very important. You have to do it in hospital setting because there are chances of arrhythmia, there are chances of vasovagal attack. Always it will be in the hospital setting, but you will not require antibiotic prophylaxis for that. So this is all about contraception. This is all about peripartum cardiomyopathy. I hope I have made things easier for you and you will be able. This is the most recent talk and definitely it can be asked in the exam because whenever there is a recent talk about the topic which is always famous, then it becomes more important in the exam. All the best for your preparation. Keep studying hard. And if you have any doubt, any comment, anything, you can put in the comment section and I'll be happy to answer. This is my introductory session, which I will be doing on 12th. And these are the topics to discuss: assisted vaginal birth, because forceps and vacuum, when to apply, what to do, everybody's confused. So I thought to discuss this, as well as the amenorrhea differential diagnosis is the most challenging one. These two topics we will be discussing. This is my number. If you have any doubt, anything, you can discuss with me. My July course, July 2022 course is coming soon and the registration has been started. So you can message me in this number if you have any queries. This is my Telegram channel. You can join the Telegram chat where you will have the daily module wise discussion of the question answers. You can put your doubt. There is a schedule to follow. So that all will help in your preparation. This is the Facebook group, all with MRCOG. So it will help you in your preparation. And I'll be happy to assist you all. Thank you very much for listening to the recording.